Even if things work, so almost everyone agrees that epidural steroid injections, work to some degree in some people. But as a society, when I mean as a society, I mean I don't mean pain society. I mean as an American citizen. So these things are very expensive procedures, and although patients feel better, it doesn't translate into really objective, improvements. In other words, people feel better, but they're not decreasing their opioids. It doesn't, enable them to go back to work. You can't even show that epidural steroid injections decrease surgery, and that's partially because the indications are so variable for surgery. You don't have standardized indications. So it's very easy. So when you look at trying to cut back healthcare costs, as a percentage of GDP, healthcare costs in the U.S. are probably, I didn't look this up, but it's probably around 18% now, pretty close to 18%. So it's far higher than any other country in the world. It's not even close. But if you look at our outcome measures, percentage of people with disability, I'll focus on pain here because that's what we're talking about. But the prevalence of pain conditions, the percentage of people who end up on disability, the percentage of people on opioids, which is far greater in the U.S. than maybe every other country combined. It doesn't seem to be better. So as a citizen, I could say, why am I going to pay for this if it's not going to enable people to go back to work? You have more objective outcome measures in, say, things like cardiologists. Okay, life is prolonged, or there are people end up having less heart attacks. So of course they're more easily accessible, but the reason that they're more easily accessible is because you had people prescribing them. And a lot of that has to do with, companies. Money drives a lot of trends in medicine and I guess everything else, fashion. But the pendulum is swinging back and forth. So the story of opioids, there's a very famous, editorial in JAMA where the editor-in-chief, I don't know if it was the president of the AMA or the editor-in-chief of JAMA, said, people dying of cancer said, don't subject, your terminally, ill patients to, to the added problem of becoming addicted to narcotics. He's saying this. And then, of course, in the 1990s, these studies started to come out, first in vulnerable populations, children, people who were, the elderly, people who were, disabled, that they had undertreated pain. So it's really a multifaceted, problem. So you had, and at the same time, you had a lot of companies coming out with sustained release opioids that they marketed inappropriately. Sustained release opioids for acute postoperative pain, and some of the companies ended up getting fined very heavily. But there's blame to go all around, right? Because then the Joint Commission started to say, well, pain is the fifth vital sign, and the person who really publicized that, Jim Campbell is a good friend, someone I admire a lot. But the Joint Commission takes this and runs with it, and how do hospitals address this? Well, they say anybody who has pain over a certain score, over a 5, it has to be aggressively treated, so people give opioids. So the consequences were really inevitable, and I would say predictable, that you started to end up having problems with opioids, addiction, deaths. And at first the legal community, people would be subject to civil and professional penalties for not appropriately treating pain. And so everyone was prescribing opioids. We had and now you got all of these people who need opioids, and now the risks start to come out. The risk of immunosuppression and osteoporosis, death. How much higher the risk ratio is for death in people on high doses of opioids, and more importantly, that opioids in the long term, in most people, there's no evidence to show that it improves function, and that the benefits compared to other treatments like NSAIDs, are minimal. So what ends up happening? So the legal system starts to go the other way. I'm from Maryland, and if you look every single month, they have people who are have professional sanctions. And the number one reason is prescribing opioids. And there's this growing number of lawsuits where patients who are on opioids and then they were cut off from opioids, or they ended up getting addicted or had some adverse consequences, successfully sue their physicians. So now the pendulum shifts. You have all these people who are on opioids, they want opioids, people like opioids, it makes them feel good, it's made them feel good for thousands of years, and then you have doctors who don't prescribe them because they're scared, or because they see now that the evidence is not in favor of opioids for most people. And so that's why you have, as the number of opioid prescriptions goes down, what do you see? You see a very large increase in the number of heroin deaths. My main area of research is spinal pain, and so that includes mechanical causes of back pain, like pain from arthritis in your back, sacroiliac joint pain, and neuropathic spinal pain, such as pain, radiculopathy from a herniated disc or from spinal stenosis. And we're shifting more towards comparative effectiveness study. So, with one of the tenets of the Affordable Care Act is that it's not that important, for someone to do the 110th study, comparing opioids to, placebo opioids, in patients who just have surgery, or doing the 53rd placebo-controlled trial comparing epidural steroid injections, the sham epidural steroid injections. It's more important, right, because this isn't a choice. The choice that the primary care doctor faces is, should I give a person a medication, or should I send them to physical therapy, or should I send them to a pain doctor who's going to do a procedure? So we're doing more comparative effectiveness research. And for example, for epidural steroid injections, which are the number one intervention performed for chronic pain in the world, a study that was, it was on the cover of Anesthesiology in November 2014, was a comparative effectiveness study comparing a series of epidural steroid injections to conservative treatment, which consisted of first-line adjuvant medications for neuropathic pain, plus physical therapy, or a combination. People can get epidural steroid injections and physical therapy medications for cervical radiculopathy, or neck pain shooting into the arm. And so that showed the combination treatment was better. So why? Well, it could be, the cornerstone of, the philosophy of physical medicine and rehabilitation, which is that epidural steroid injections provide a therapeutic window. It doesn't last for a long time. It certainly lasts for maybe 6 weeks, but probably not 12 weeks. But if you take that opportunity and you start to engage in more physical activity, physical rehabilitation, you can reverse some of the deconditioning, and you can prolong the benefits. And it may also be that these people had a higher placebo response rate. It's like winning the lottery. There are 3 groups. One group is going to get epidural steroid injections, one is going to get medications and physical therapy, and one is going to get everything. And the patients would say, no, I want injections, I don't want medications. The people who get combination. So certainly, your expectations are high. That's integrally tied into the placebo response rate. And that's one of the big, that's like the 800-pound gorilla for clinical trials. So for all of the top medications for patients, I can guarantee that the placebo effect of these medications is greater than the intrinsic analgesic effect of the medications, right? So the clinical trials that lead to the approval of drugs like duloxetine, gabapentin, pregabalin, usually show a difference of maybe 10, 15%, a little bit more than 15% above placebo. But the placebo effect and the placebo response rate is higher.